Thank you very much, Lydia, and thank you to Enter, my friends at Enter, for inviting me to speak. I guess a little bit of a note of caution, really, for what I'm going to present. I won't be presenting significant research results, more reflections on how recovery has evolved in all the years that I have been involved in this. And I had the joy and privilege of being involved in Enter for very many years. And I know a few of the names and faces I see in the list, and I've had the joy of meeting some of you face to face in years gone by. But I think when I spoke to Emma about preparing for this, it really became um, I became conscious of just how long we've been talking about recovery. And I think it's probably worth stepping back and thinking about where recovery came from, what it means to people, and where it might be going in the future. So that's what I'd like to talk about, and I'm really happy if there are particular questions that people have, that they do use the question facilities available, and we can come back to them at the end of the presentation. Um, my perspective is largely based on my UK experience, but also having had conversations with many people from Europe and beyond. And for those of you who are not familiar with me, it is very much from the experience of someone who spent their time early, from early teenage years through to really into my 30s, going in and out of psychiatric hospital at a time when recovery was really not talked about at all. And so for me, just the fact that we have conversations about recovery is an enormous step forward on a culture that took people like me, who were defined and described as mad, and locked us up out of harm's way for a lifetime. And I guess I represent one of the first generations who will have lived most of their life with living with a number of psychiatric diagnoses, including schizophrenia and personality disorder, in the real world, doing real things with real people. And this was an opportunity just not afforded to many of my predecessors. So I do feel that I'm speaking from a position of some privilege compared to those who came before me. So recovery. I first came across the notion of recovery back in a time that historians would refer to as the 80s, the 1980s, even a millennium ago, and it came out of the rise of what we then referred to as the survivor movement. Those of us who had lived with psychiatric diagnoses and had seen many other disadvantaged groups start to reclaim their basic human rights. And I think we in the mental health field, in the survivor movement, were quite late to the party, really. So we saw we saw the growth of gender equality movements, race equality movements, and disability movements, all through the 60s and 70s and into the 80s. And I guess in the very in the middle of the 80s, that was when we started to take things quite seriously. And you hear you see the birth of organizations like Survivors Speak Out and the Hearing Voices Network, and so on, around that kind of time, mid 80s, really. And when recovery started, certainly from my perspective, it was something that we owned and defined. It was about us wanting to get back to the world that had been taken away from us. And I think it didn't stay like that for long in the UK. And the first thing that happened to recovery that I can remember, after we got very excited about it and thought that this was something that could really change the way we were treated and lived, was that it got co-opted. And like many things before it and probably since, what started off as our idea, as our mission, we became partners in, and then we became junior partners in, and then our NHS in the UK took it over, and it became almost a brand. And you could not find a mental health service by the early 2000s that would not describe itself as recovery orientated. And all of a sudden, it had gone from being something precious and radical and progressive to a tick box exercise that could be delivered by any half decent service manager to the satisfaction of the people that they were accountable to. And that was the thing that first rattled me about recovery. And then the second thing I think that happened was that a lot of people started to worry that recovery, rather than being something that identified us as progressive and different, was slotting us very neatly into a medical model that we didn't actually believe in. So we started off as human beings, we became ill, and then the idea was that we'd recover and then come back to being human beings again. And more frustrating than that kind of slotting into a model that a lot of us didn't think fitted was the fact that it wasn't even us that decided whether we'd recovered or not. It was actually about fitting us neatly into that medical model that said illness, treatment, cure. And it was psychiatric professionals who were making that judgment as to whether we were or weren't recovered. And I think that concern absolutely continued when we saw the rise of the recovery worker. And I'm not going to spend too much time in this territory because I know Karina has much more interesting and contemporary things to say about recovery in workplace settings. But one of the characteristics of the recovery worker, and I went through countless job descriptions, and we used to just collect them, and they almost all would say, person with lived experience of mental health who has recovered. And that's kind of like, okay, that's it. You've done your mad bit. You can come back to the real world, and now you can be a recovery worker. And that was, again, just so much of that seemed to lose the sense of community that we had found so valuable by coming together in the survivor movement. And I think there was a feeling that we lost that. And then there was there were some really good people who did some really interesting work that was around critically appraising recovery and reclaiming recovery. And for me, that was very much about going back to our roots in what we never really thought of as the recovery movement, but what we might now think of as the recovery movement. And that was saying, well, okay, who has the right to say whether we have recovered or not? And that lives with us. And that is absolutely fundamental principle of recovery. And if you come across anything, that calls itself recovery, where someone other than the person, whose life we're talking about is describing and defining that they have recovered, you just need to be a little bit suspicious. Because psychiatry has a long history of making judgments on us, about us, and when we don't take those judgments well, we lack insight. It's a symptom of our delusions or illness or psychosis, and the control is slipping away from us. So I think what is absolutely fundamental to meaningful recovery is a sense of ownership of the definition of recovery. So we describe what we mean by recovery for us, and it may be very, very different. And I know Peter will talk about hearing voices and experience. It is absolutely possible to hear as many voices as you like and still live a full and recovered life. It is not about being stopped from hearing voices. Now, for some people, it may be escaping the voices, but others, it may be living with it. It may be benefiting from the voices and living alongside the voices. And that's what recovery might mean to you. And it is not for me or anyone else to tell you whether you have or haven't recovered. It's about you understanding, owning, and defining that recovery. And I think that's really important. Um, and I guess once we started to get the hang of that, then we could do something constructive about it. And I got really excited in the um, early 2000s when I joined the Mental Health Foundation. And the question given to me when I joined the Mental Health Foundation, the organization that I work for and pays my salary, was, you know, what does it mean to be in control? What does service user involvement mean in the new millennium? And we'd done all this business of being on committees and being involved in engagement exercises and so on. What we really wanted was to be in control of our own lives. And so what we set out to describe and define recovery was very much based on some of the models of self-management. This idea that, and it was very well developed in long-term conditions, and it was very well developed by work done by what was then the Manic Depression Fellowship, now Bipolar UK. And it was about taking control of managing your condition, which in physical long-term conditions worked really well. But in mental health conditions, it was having a very variable effect. And we looked at why it was not working so well in mental health as it clearly was in long-term conditions. And there seemed to be three principles that it was based on. One was that you had a condition that was very well behaved. So you knew what your condition was and you agreed that you had it. And that was your starting point, which works quite nicely for something like diabetes, and it works quite nicely for something like arthritis. And actually, some of my friends with a bipolar diagnosis say it works quite well for them. Then you need condition two, you need a treatment that works. Or some treatments that work, or interventions that work. And again, in some places, you can see exactly how that model fits nicely, and it fits nicely with this notion of recovery. You have a condition, you have a treatment, it works, you recover. And then the third thing that classic self-management requires is a very good relationship between the clinicians who used to have control and the patients you want to have control. And that you have a nice smooth handover of control of your condition from clinician to patient. And again, when I grew up, my father had diabetes, and I could absolutely see the evolution of control of diabetes from a consultant who would tell him what his dosage of insulin was every day, even though he only met him every 6 months, right through to a time when my father would monitor his own blood sugar levels hourly if he needed to, adjust his lifestyle if he needed to, and if that failed, adjust his insulin levels if he needed to, and he was genuinely in control. But that model, excellent though it was, and beautifully fitting a particular model of recovery though it did, just failed for so many people, and particularly so many people with the diagnosis that I had. I had 6 diagnoses, but the last one I had, which was schizophrenia, because schizophrenia is not a well-behaved condition, if it's a condition at all, and even that is contentious. Treatments, even if you believe it is a condition and you follow the best guidance for the best interventions for it, that seems to work for about a third of people, even if you just buy the straightforward medical model role. So we don't have good, effective treatments for the majority of people with the diagnosis. And finally, I would definitely not characterize my early experience as a teenager and someone in their 20s as having a good constructive relationship with my clinicians. Yeah, that came an awful lot later. And so all those conditions that seem to be necessary for this model to work well were not met by so many people. And so what did we do about it? We started setting our own conditions, and we decided that what we needed to do for our version of recovery was live in the context of our diagnosis. and again, I'm choosing my language carefully, not in the context of a condition, but in the context of the diagnosis. And we took the view that you didn't have to believe your diagnosis, you just had to have it. Because we thought having the diagnosis was an important marker of disadvantage. Or a certain, no, let's be fair, I'll try and be an objective, a marker of difference. So there is a difference between a person that does and doesn't have a diagnosis of schizophrenia. That's about the diagnosis, not about the condition. So what we set out to do with our model was think about how do we live the best possible life we can in the context of the diagnosis. And the active ingredients we chose were goal setting and problem solving. So what is the life that you want to live? And what are the things that are stopping that happen? And that is still what I think of and believe to be the genuine meaning of recovery, that I can trace back all the way to my first discussions about it, and even before we were using that language, many, many centuries ago. And so that's kind of what we did. And then I guess what happened next, which was my second big revelation on this, was when we asked people, and we worked with a lot of people, and we were fortunate enough to have we put this together as a proposed intervention, and we got the best part of €1 million to deliver it. And we worked with 650 people in over 60 different peer groups. Every single course that we ran around this was delivered by someone who was either involved in the development of the course or had previously attended one of our courses. So it was absolutely all led by us, people with lived experience, people living with a psychiatric diagnosis. And the first thing we discovered was that almost everybody struggled to set their own goals. And the reason they struggled to set their own goals is because historically everything they'd been told was what they couldn't do, and nothing they'd been told was what they could do. And so we went from this model of self-management, which is about how can you get your best possible life, to self-management and peer support, which is how can we get our best possible lives. And what we found was people were much more ambitious for each other than they were for themselves. And they were much better at problem solving for each other than they were for themselves. And that kind of collective sense of recovery, that sense of community, that idea that we are not just problems that need to be solved, but we are actually, we are people who have something to offer as well as need something back, was just reinforced in this notion of self-management and peer support. And again, this was nothing new. It's just that we were formally applying it in a particular setting, in a particular way, with particular groups of people, in a way that made sense of recovery to us. How am I doing, Lydia, on my time?
Still 5 minutes.
5 till my 25 or 5 till my 30?
5 to your 25.
Okay, lovely. So what we concluded from this, and we wrote it up and we published papers, and there is research out there which I can share with folk, and many of you will have seen it before, is that, recovery can be important and life-saving, but it needs to be defined by us. And that is something that we can do collectively and share. And it is something that we can do in a cross-disciplinary way as well. And I'm going to step out a little bit outside my natural territory of mental health and talk about one last project I was involved in, which was phenomenally interesting for me, largely because I could genuinely look at it from one step removed, which was some work that I was involved in around mutual recovery that looked at women who had traumatic births and midwives. And as I have never and never will be a mother or a midwife, I was a strange person to be asked to lead the engagement in this, but The woman who did it precisely because she wanted someone who wouldn't be embarrassed about asking silly questions. And believe me, I asked many silly questions. But one of the things that was absolutely fascinating about that was the real benefit of mutual recovery with midwives and with mothers who experience traumatic birth. Because one of the things that three of the midwives that I spoke to said to me that I'd never even thought about, and that had just has just stayed with me since, and really indicated that they needed recovery and support as well, was that they have to go from moment to moment, from someone who is having the best experience of their life to someone who is having the worst experience of their life, and back again, with the best possible expression on their face, with no preparation, and just get on and do it. And I cannot imagine, I've gone through some mad stuff in my life, but I cannot imagine what that is like as a job. And the idea that it just becomes obvious that that's something you need to recover from. And of course, the mums who'd experienced traumatic birth don't think about that, don't experience that. So this particular project that shared these experiences across those two groups was genuinely transformative and was genuinely about sharing recovery. And it wasn't about midwives telling mums how to recover, and it wasn't about mums telling midwives how to recover. It was actually about sharing the language of recovery, talking about mutual recovery. And sharing those vulnerabilities and sharing those coping strategies, and that genuinely healed people in a way that I've never seen in another field. And I'm absolutely convinced it was because there was a genuine acceptance from both groups that recovery was important and was needed, and the discussion about it needed to be shared. And so many of those midwives talked about, on the one hand, the importance of professional boundaries, but on the other hand, the value of having space to share those experiences and to listen to the experiences of the mothers as well. And that's the kind of example I will leave with, because I think it is genuinely possible to share recovery across professional boundaries. And I've seen it done, and I've seen it done in a remarkably moving and effective way. But to do that, everyone involved needs to be prepared to take and share those risks and support each other through the process. And it is much rarer to see that kind of thing happening in mental health services than I think it should be. And that's where I'll stop, because I know there are some really interesting presentations to come.